Okay, so I'm going to introduce Dr. Lionel Bercovitch now. As I said earlier, Dr. Bercovitch was the person who diagnosed my kids. He may or may not mention that in his talk, and I have, in some sense, given him a lot of work to do since he met me all those years ago in 1994. He is a primary person as a go-to for us around PXE because he has seen so many people with PXE. He's a dermatologist, but also has a background in ophthalmology as well. So kind of the perfect PXE clinician. So Lionel, I'll hand over the microphone to you. And you're muted. Let's see, I'm trying to get you unmuted.
There you go. All right. Yes, the host has to unmute people. Can I share my screen too?
Yes, please.
All right. Let's see. All right. Does that look okay?
Yes, it looks great. Thank you.
Good. Well, thank you, Sharon. Greetings from sunny but chilly Providence, Rhode Island, and I guess it's still morning here. It's probably afternoon over in evening, early evening in Europe and South Africa, and I don't know where else we're being heard right now, so I can't really guess what times it is elsewhere. I'm going to talk about PXE in the skin. Certainly not the most life-threatening or vision-threatening aspect of PXE, but it's certainly the one that is the most visible to everyone else. So I'm going to just do this for a second here. So skin criteria are part of the diagnostic criteria of PXE, which is not to say that everyone has visible skin manifestations, but the two major skin criteria are the presence of the typical PXE skin lesion, and I'll talk to you about those in a second, or the typical criteria under the microscope, and I'll show you some of those as well. And either one major ocular criterion, usually angioid streaks or peau d'orange in younger individuals, or two pathogenic allelic mutations of ABCC6. So these are not formally published criteria, but these are the most modern ones that we've all agreed upon in the last 10 years since the discovery of the gene and the availability of the genetic test. So it's possible to have no skin criteria, but just have eye findings and a positive genetic test. It's possible to have minimal eye findings, although eventually everyone has some eye findings. Genetic testing is not required for the diagnosis. So I'm going to focus on the skin criteria. So dermatologists speak of primary lesions, and a primary lesion is a skin lesion that's undisturbed, so it hasn't been picked open, it hasn't been infected, it hasn't been scratched. It's just the actual lesion itself. And we speak of papules, which are generally you would think of as a bump in the skin. Some people would use definition of under 5 millimeters, which is what it generally is in PXE. Some use under 1 centimeter, or a plaque, which is just basically an elevated lesion that doesn't have much depth, that is 1 centimeter or greater. And generally what happens is papules will coalesce or come together to form plaques. In more advanced stages, the skin can become, so these are the primary lesions of PXE. In more advanced stages, the skin becomes lax and forms loose folds. So the skin is the earliest and most visible site of involvement for most individuals with PXE, especially females. In some of the studies that we've done through the registry, we have found that in general, the majority of females are diagnosed by dermatologists. But to a greater extent, men are diagnosed by their ophthalmologists. Although in general, most people are still diagnosed by skin biopsy, but because of the visible signs on the skin. The earliest involvement is on the neck and then the underarm or axilla. These are the areas that are most frequently affected. But there are other areas of involvement that can include the crease in front of the elbow, the so-called antecubital fossa, the groin, the popliteal fossa, which is this crease behind the knee, the skin around the umbilicus, sometimes on the upper chest, and also in the inner aspect of the lip. We consider mucous membranes to be modified skin. They really are microscopically very similar to skin, except in lacking a scaly or horny layer. And in addition to the inner lip, it's also found in the vaginal mucosa and in the esophageal mucous membranes. So there can be fairly extensive involvement in terms of areas involved. The papules are either circular or oval or irregular or rhomboid in shape. They're generally somewhat yellowish, and that's where the term pseudoxanthoma and pseudoxanthoma elasticum came from. Xanthoma is generally a cholesterol deposit in the skin, and it has a yellow appearance. That's where the term xanthos comes from. And they can be yellowish or yellowish orange or grayish yellow, or even a sort of yellowish skin color. The neck skin may actually look unwashed or have a cobblestone look. Sometimes you'll hear the term plucked chicken. I think it's a very poor term. It doesn't at all look like plucked chicken. Number one, and number two, I think it's just an unacceptable name for a human skin condition. But here's an example here of you can see where the arrow's pointing, of these yellowish papules on the neck of the skin in PXE. Here's another example. These are almost more skin colored, but I mean, I can see it on my computer, but they have a yellowish hue. It may not be as obvious to you. This is actually a young woman in her early 20s when this was taken. Here's another patient, and you can see here the sort of more oval and elongated nature of these lesions that are actually somewhat coalescing to form plaques over here. And here's an example where the skin of the neck has become more lax. You can see the extra folds, but in addition, you can see the yellowish, almost reticulated plaques over here on the side of the neck. And here's the underarm, and you can see here yellowish papules forming. This is not a normal finding in the underarm skin. You may see prominent hair follicles, but these are not hair follicles. And here's an example of both papules it's on my left. I'm not sure which side it's on with you, but where my cursor arrow was pointing. And on the other side, where the skin is a little bit darker in color, you can see these are more plaque-like. This is an extreme example of laxity of the underarm skin. Not a very common finding, but this is an extreme example. This is the skin of the crease in front of the elbow, or the so-called antecubital fossa. You can see here there's crisscrossing papules and plaques. Here's another example of multiple papules in the skin of the antecubital fossa. This is something you can see in some patients with PXE. If you look at this insert on the upper right corner here, you can see yellowish markings on the inner aspect of the lower lip. It's more prominent over here. Now, sometimes you can see whitish lesions under the inner aspect of the lower lip. Normally, and these are called Fordyce spots. They're also seen in the penis and the vagina. They're sebaceous glands. They're not the same. These are not sebaceous glands. These are not oil glands. These are actual pseudoxanthomas forming. We call them pseudoxanthomas because they're not true xanthomas. They're not cholesterol deposits. This is another interesting finding that Mark Lebwohl first observed at a early PXE international patient meeting. I think probably sometime in the 1980s. Mark and I photographed many patients. In fact, we tried to photograph everybody who was at the meeting. and to see how common these were and what the sort of and to analyze the way they looked and the age of patients who had it, together with Mark's daughter, I think, who was a senior in high school at the time. And we found that these are actually a normal finding in older people, especially those with sun damage. But we were finding these in women in their 30s with PXE. And we don't really know why that is. We biopsied a couple of these and it didn't show evidence of PXE. So I don't really, it's not a characteristic area where you'll find skin lesions of PXE. So I don't know what the actual mechanism of these forming is. Another example over here. So one of the ways we diagnose PXE is by skin biopsy. And skin biopsy is really not a big deal. I mean, may sound scary, but it really isn't. We here's an example. This is taken from a South African practices website, but there's an example here, biopsying something on the face. We use something called a biopsy punch. It's a little coring tool, and we just basically twirl it over the lesion. It's got a razor sharp edge, and a little core or plug comes out, and we just close it with one or two little sutures just so it'll heal nicely. And it's painless. It doesn't hurt afterwards. Generally heals with only a small scar. And very often in PXE, especially on the neck or under the arm, it may heal with no scar or very limited scar. So what do we look for? Well, this is a skin biopsy that's been sliced and then stained. And you can see here at the top, this is called the epidermis, and then this is called the dermis. And if you go deeper, you'll get to the subcutaneous fat. These are the three layers of the skin. And it's hard. I mean, you would, without really having any kind of experience looking at skin biopsies, I'm just going to show you what you're actually seeing here. And these little purplish clumps here, which are magnified inside this insert, are elastic fibers that are kind of ragged and curled up and have some calcification, which gives them this darker purple look here. Ordinarily, you wouldn't see this to this extent. And this is fairly deep in the dermis. Usually when it's due to sun damage, you might see it more superficially. We also use what are called special stains. These are stains they're like pigments that have an affinity for certain tissues, and to help us characterize abnormalities better. So there are a couple of stains that are used to highlight elastic tissue, and you can appreciate here, these are kind of clumped, irregular, short elastic fibers. These are not what normal elastic fibers look like. And this is also in the mid to lower dermis. And this is the characteristic site at which PXE affects the elastic tissue. You can see here in the very fine, small elastic fibers, or fine elongated elastic fibers in the more superficial dermis, that these are more normal. And then we also have special stains that highlight calcification. This one's called alizarin red. There's also one called von Casa, which is more widely used. But you can see here that these elastic fibers are also calcified in the lower to mid dermis. This is a von Casa stain, and you can see here the elastic fibers are stained, pick up the stain, which makes the calcification look black. So this is sort of the gold standard in microscopic diagnosis. But a lot of pathologists feel they don't need to do this. They can make the diagnosis with just a light microscopy without any kind of staining. So you've all heard the expression, if it looks like a duck, walks like a duck, and quacks like a duck, it must be like a duck. But there are things that look like a duck but don't quack. In this case, don't walk. There are, every once in a while, we have referred to PXE, somebody who's diagnosed by their dermatologist as having PXE. They look for all the world like they have PXE. The findings are absolutely identical. I mean, I would defy you to make it to differentiate what they have in their underarms and neck from true PXE. But they have no eye findings. They're diagnosed at a fairly advanced stage, usually in their 60s or 70s. And these conditions used to be called white fibrous papulosis of the neck, or PXE-like papillary dermal elastolysis, meaning that the elastic fibers in the papillary or most superficial part of the dermis are broken down, or papillary dermal elastosis, where they're sometimes thickened in this area. And it looks identical to PXE and can even involve the same areas. You can see here the mean age is 62 years. Unlike with PXE, where the skin findings usually occur in the second decade, usually in teenagers or in their 20s, sometimes even in the first 10 years. I know Sharon's kids both had the skin findings when I think they were 5 and 3 respectively, which is very unusual. And also involves females much more so than males. Under light microscopy, they don't have mineralization. And you can see here the elastic fibers are affected, are normal looking here in the upper dermis, and they're nice, spindly, long, elongated elastic fibers here in the lower dermis, unlike PXE, but they're absent in the papillary dermis, where it's nice and pink over here. This disease is not thought to be genetic, and it's not PXE. And so usually when I hear the story, I'm almost always able to tell that's what this is and confirm it by just reviewing the skin biopsy or look at the skin biopsy. So as I mentioned earlier, females are more likely to develop visible signs of PXE at an earlier age than males. Females are more likely to be diagnosed by dermatologists. Males are more likely than females to be diagnosed by an ophthalmologist, but in general, most diagnoses are made by dermatologists. Ludovic Martin, it was one of our colleagues and researchers in France, and his associates published an article in the British Journal of Dermatology where they looked at their own registry of patients, and they found that the extent of pseudoxanthoma elasticum skin changes was related to cardiovascular complications and visual loss, in the sense that there was a statistical correlation between the number of affected areas and the presence of severe cardiovascular events or ophthalmological complications. But this is a statistical association. Those of us who see patients with PXE know that there can be a wide variation, even within families with identical mutation, between the severity of skin involvement or the severity of cardiovascular involvement or eye involvement. You can have family members with pretty widespread skin findings or a lot of laxity of skin and minimal cardiovascular findings. And you can have patients who have almost no skin findings, but have very prominent eye findings. So it's really not it's an interesting study. You may see it quoted, but it doesn't help in individual cases. So the question is, what can you do about this? Well, lax or redundant skin can always be tightened. So there are various ways you can do it. Sometimes you can actually just bunch it up and remove it, and then stitch together the skin at either end where you've removed it. You can do that in the neck. You can do that on the underarms. Or you can do what's called like an abdominoplasty, like when it involves the groin, where you actually remove the redundant tissue in the groin, and then just like you would tighten a bed sheet in making the bed, you then tighten the abdominal skin and stitch it back into the groin, so that, and similar techniques are used in doing facelifts, where you can actually, remove excessive skin and then try to place the incision under the hairline so that it's not really visible. So there are techniques such as that can be done. Problem is that those, well, I'll tell you in a second. The problem is that those types of surgery don't really change the underlying disorder. You can tighten the skin, but you're really not, and by removing excessive or redundant skin, but you're still going to leave behind skin with the papules and sort of cobblestoning of PXE. In general, patients with PXE heal well, but patients should have pre-op cardiac evaluation. I mean, anytime you're going to undergo general anesthesia or an extensive surgical procedure, that's especially if you've got a disease that's associated with cardiovascular complications, you need to undergo pre-op evaluation. Smoking impairs wound healing. And although we really strongly advise against patients who are already predisposed to arteriosclerotic cardiovascular disease, which is aggravated by smoking, combine that with PXE, and it's a double whammy. And PXE and plastic surgeons in general avoid doing cosmetic procedures on those who are active smokers because there are issues with increased difficulty with wound healing. So as I mentioned, it has no effect on the underlying process of normal aging, and eventually laxity will recur. In general, the skin in PXE heals uneventfully, and about 75% of patients tend to be satisfied with the outcome. So patients with PXE do heal okay. I mean, I think that there's always concern that is my scar going to discharge calcium, or am I going to have a thickened scar? And that those don't seem to be problematic in patients with PXE. Here's an example of somebody who's actually in South Africa who underwent a removal of excessive or lax skin in the neck. And you can still see the papules here, but the skin no longer has the lax appearance. Eventually, just like with a facelift, it's just probably going to recur, but it can always be done again. There's probably also a significant degree of sun damage here, because one thing you do better as you get older, particularly if you have more sun damage, is your skin heals better. You tend to hide scars better, and scars are much less conspicuous. I wish I could give you more information on laser treatment in PXE. There's a whole new generation of carbon dioxide lasers called fractional CO2 laser. And they've been actually used successfully in patients with the so-called fibroelastic papulosis, the patients that I showed you examples of that look like PXE. But there, the changes are much more superficial. Here, the changes are quite deep, and that may actually have bearing on how much you can expect from laser treatment. But there's really only been one case published in the literature. I'm sure there have been people who've attempted this or had undergone fractional CO2 laser therapy, but none of it's been published, so we really don't have any information on the that we can access unless we have access to somebody's records, for example, who's undergone this. And of course, the molecular defect persists. So the skin itself is, as Sharon mentioned, we're still looking for a biomarker. The skin itself is first of all, we don't know whether the changes in the skin are really reversible with any kind of treatment. So it may or may not make a good biomarker for whether a treatment is effective, number one. And number two, it's so variable that somebody may have significant ophthalmologic disease or cardiovascular disease. As I mentioned, it may have minimal skin findings, so it's very difficult to tell whether it's really, by looking at the skin, whether it's going to mirror something that's going on under the skin or within the body. So I think it's certainly the most visible part of the disease. It's certainly one that may affect someone's self-esteem and self-image, and it's something that deserves all the respect that it gets, and probably more. But in terms of being a marker of severity of disease or something that we can use to monitor therapy, we're not there yet. So that's what I have to say.
And thanks, Lionel. We have some time for questions.
Sure, be happy to.
How about put down the stop screen sharing, and then we can see everybody.
Okay, yeah. Let's see, stop share. Yep. Okay, there we go.
Great. Thank you. Thanks very much, Lionel. Great overview. Okay, questions, you can put them in the chat, you can unmute, you can use the raise hand function, you can wave wildly at us, whatever would be useful for you. Opie?
Hi, I have a question to the doctor. So after being diagnosed, I've been digging around for a lot of information. And I realized that what I had on my upper chest, the skin, there is a skin difference, is possibly for PXE. In fact, since my teen years, I've had this, and I've visited numerous dermatologists. I grew up in Canada. I live in US now. I've visited dermatologists on both sides of the country. No one was able to determine, even as recently as January 2020. Is there a reason for this? I'm just trying to, I know there's not a lot of information here to see, but I'm just trying to see, should I be going to a dermatologist who specializes on PXE, or what was the issue that kept, the dermatologist couldn't come up with something. They couldn't even remotely just say this possibly could be. So I'm just wondering.
Well, without seeing it, I can't tell you.
I agree, yes.
You're not going to show it on the screen here.
No.
So I don't know. You can see PXE changes on the upper chest. And usually you can tell, if you know someone has PXE, it's usually pretty obvious whether it's PXE or not. So I don't know. I don't know why it was so difficult. I mean, that's a tough question to answer without knowing what it looks like. But I mean, there's certainly, if there was any question, it could be biopsied very easily, and that could answer the question. You could take a 3 millimeter biopsy punch and make a very, just a very small biopsy would give you the answer as to whether it's PXE or not. In general,
no, actually, it was later diagnosed with genetic test, as well as because of a ophthalmological issue. I actually had a retina vein occlusion, lost my sight. And so that is how all of this came to be for me. But after reading, I've been doing a lot of reading, digging around, and I realized that I had this on my skin, but no one was able to tell anything about it. So that's what I was.
He means a biopsy of that particular skin. I don't think he's doubting your diagnosis. It's more, if they did biopsy that skin, they could do one of the stains Lionel showed and then decide if that was PXE or not.
It's interesting that, I mean, central retinal vein thrombosis is not to my knowledge, is not a feature of PXE either.
Right.
So I don't know. Were there angioid streaks in your eye? I mean, was there something else that said this was PXE?
It was angioid streaks, that plus the retina vein occlusion, loss of sight, and the fact, so that kind of prompted my retina specialist to then ask me to go. Yeah.
Well,
The
angioid streaks, of course, is the diagnostic finding.
Right. The retinal vein occlusion is not part of PXE. Okay, we have several questions in the chat, and then Gretchen, you're up. So 2 questions in the chat, then Gretchen, then 2 more questions in the chat. Lionel, with the facial folds around the mental creases around the chin, if a person did have a facelift, would those come back eventually?
Well, you know how it works at Best Buy? You go to the cash register, and for a little extra, you can get a 2-year warranty or a 4-year warranty. Everything with PX, every type of facelift comes with a 90-day parts and labor warranty. After that, whatever caused the original problem, aging of the skin or sun damage or whatever, I mean, you're going to eventually be subject to recurrence. So my guess is, like with any kind of facelift, with an aging change, this is just an earlier change. Yes, it could recur, but how long it could take 10 or 15 years. It might take 5 years. It's just unpredictable. But you got 90 days free.
Yeah, and also the other thing we should note is that is not just PXEers. If you start walking around looking at people in grocery stores and other places, you'll see that in other people as well. Yeah. Okay, next chat question, and then Gretchen. I recently had some collagen injected, but I would say the results are not as predicted. should have resulted in more enhanced plumping after 2 or 3 months. I'm not seeing that. Is this not practical with PXE?
That's a good question. Collagen is not really used very much as a filler anymore. There are hyaluronic acid fillers and other type calcium appetite fillers. It's probably, I'm sure there are other fillers that might work better. And again, it depends on the scientist. I'm a pediatric dermatologist now. The age group I deal with doesn't get fillers, so I don't get a lot of experience dealing with them. But there's a very wide range of fillers that are now available, and depending on injection technique, they can be very successful. And so I think that's something you need to take up with whoever did the filler injections. But they're not contraindicated in PXE to my knowledge. But again, I think there's very little there. I'm not aware of any published experience. It's just too bad, because people, if we knew more about, if we had more objective information to go on it, we could give much better advice. I think it's one case here and there, or a patient's report isn't as helpful as having, published medical peer-reviewed publications with good photographs and or microscopic description, or even just cataloging of complications.
Yes. Again, this is a reason why we ask you to answer the surveys, because you'll be able to describe your experience and help others. The other thing I'll say is,
but I want to say one thing, that most of the skin areas that are affected by PXE generally don't need filler. The areas that tend to need filler, like the nasolabial folds, the creases around your nose, marionette lines on the chin, deep troughs under the eyes, that sort of thing, are generally not affected by PXE. So, they should work pretty well like any other. You shouldn't be any different than any other patient, and they should be safe.
right. And we do have a recorded presentation last year by a plastic surgeon who basically, his bottom line was, for the PXE part, and Lionel's right for the aging parts, but for the PXE part, generally nothing works the way that he wished it did. Okay, Gretchen.
Hi, I just wanted to say thank you for your information and thanks for being here. I had a quick question about radiation. I had breast cancer and radiation treatments, and I have papules on the back of my neck and in my underarm area. And I was just wondering if I've noticed skin changes, obviously, if there was any effect on the PXE skin and radiation treatments.
I think as Sharon, you can refresh my memory, but I think we asked around about 15 years ago whether anybody with PXE had undergone radiation, and I think we had 1 or 2 patients, and as I recall, there were no particular issues.
Right.
But yep. there isn't a lot of information. We did this around the time we did the mammography study, because we actually did come up with a couple of breast cancers in that group.
Right. And yes, another area that people answering the survey would really be helpful. But in general, both the stories that we've heard, which is not science, but also the several people that we interviewed said there was no difference. Okay. Lionel, are there any cosmetic or aesthetic procedures that should not be done when one has PXE?
Well, that's a good question. In terms of skin that's not affected by PXE, which is facial skin for the most part, I don't know that there's any procedure that's contraindicated. And for the skin affected by PXE, usual desires either to resect skin or to tighten skin. So I'm not aware of any issues there either. I'm not aware of any procedures that make PXE look worse, but there are probably several that don't do very much, and I guess technically could make things worse. For example, we don't have any published experience on ablative laser surgery where you're removing layers of skin and PXE, whether whether the healing response there is normal or not, because there's nothing published, so I can't tell you much about that. I think in general, if you're going to undergo any kind of procedure like that, and I do that with when I treat, sometimes when we treat port wine stains with laser or other birthmarks with laser, do a test spot. Do a small area, see how it responds and how it heals before you do all the skin. A little test spot, centimeter by centimeter, will give you enough information to know whether it's safe to do. Whereas if you do the whole thing, you can't then go back and undo it. So if there's any question about it, just treat a small area and see what happens.
Great, thank you. Question, does Trentanoid, I'm not going to be able to say that right, TRE, yeah, does that help? Yeah, does that help?
Yeah, tretinoin is Retin-A. It's a retinoid. It's an acne medication. And as you know, it's been used for treating fine wrinkles. The mechanism of what it does is it causes there to be a very fine layer of collagen laid down under the epidermis. It kind of plumps out very fine wrinkles or camouflages some of the changes under the skin. The short answer to the question is no. You're not going to really make much, and it's been tried. I remember years and years ago, I wondered whether there's another retinoid called tazarotene or Tazorac, which is a more potent retinoid, and somebody had published in a monthly thing we used to get from a pharmaceutical company, Neutrogena, called the shock letter, which was full of all sorts of unpeer-reviewed and untested hypotheses and treatments that have been tried on one patient, and suggested that it had worked in a patient with PXE, but it might have just been solar elastosis for all I know, just sun damage that looks like PXE. And I've tried it in patients, and we did this back in the 1980s, and I don't think it did anything. I'm not convinced that it works. There's no harm in trying it. It's certainly, there's no, but you have to be careful because it can be very, so it causes dryness and acne when you're putting over large areas like over the neck. It can probably be very drying, but there's no evidence that it's effective, but it's not harmful.
Okay, and Lionel, is there any downside not treating the plaques, papules, folds, just leaving them?
Is there any
downside? Is that
No,
should
no.
one be proactive?
No, you're not. You're not treating anything really other than the cosmetic appearance. Nobody's ever died of a papular plaque, and nobody's ever lost vision because of a papular plaque, it's a marker of the disease. It's certainly one of the most visible areas affected, but it's not prone to skin cancer. It's not prone to any kind of malignant degeneration. The worst that can happen is sometimes you get, besides becoming lax, and sometimes the laxity can be a little uncomfortable, is every once in a while, so you can get what's called perforating PXE, where a little bit of calcium discharges through the surface of the skin, but that's harmless. So no, there's really no medical indication for treating it other than cosmetic, unlike cardiovascular and eye problems.
Great, thanks. Someone writes, my affected skin on my neck is prone to irritation from metals and other materials. Is there any specific ointment recommended?
That's an interesting question. So I don't know exactly what the person who wrote that question means, but metal allergy is very common, especially in women. About 20% of women who are patch tested are allergic to nickel because it's they get their ears pierced and get sensitized to nickel at a very early age. So if it's an allergy to nickel and that's causing a rash, or metals are causing a rash, then that's not, then it's an allergy. You can't undo it with any kind of ointment. You can treat it with a steroid ointment, but you can't prevent any kind of changes other than you not avoiding metals containing nickel. And you can buy spot test kits over the counter that tell you if there's nickel in the metal. If it's actual irritation from rubbing, then I suppose a barrier cream might help, but if you can find one that doesn't look, like a diaper rash cream. But in general, I think that if there's certain things, it's like saying if you get a headache when you bang your head against the wall, don't bang your head against the wall. If your skin becomes irritated by wearing tight collars or wearing jewelry around the neck, then just don't wear it. But if it's an actual rash or allergic reaction, then that you can get around that by just avoiding the metal that causes the allergy. And there are plenty of metals that don't do that, especially gold and platinum if you're inclined to finer things in life.
Okay. Any other questions?
So I'll be back in about, it looks like 4 hours and 20 minutes when we have our panel. If there's more questions that come up, I'm certainly available to answer further questions.
Great, thanks, Lionel.
Okay.
Okay, thank you very much. Thanks for all your years of service. Quite incredible. 26, coming up on 27 of them. So